Paul, P as in Patrick, Hinchy, Hinchey, CEO.
Great. And so, as the person kind of at the helm of this hospital, what are you seeing, or what are you hearing from doctors, nurses, everyone, as we seem to be going into another spike of COVID-19?
Yes, we're living right now in unprecedented times, and as you just said, I've been at ground zero for the last 17 months. So we've seen the good, the bad, and the ugly of this, and it is literally changing by the minute. And the inpatient census that this community is experiencing now for COVID-positive patients is extremely alarming. And I'll put that in context numerically for you. When this thing hit the fan 15 months ago, pre-vaccine, the high census here for 2 hospitals was about 98. Right now, today, when I came in, Saturday when I called in, it was 145. When I came in today, it was 158. So those numbers are numbers that we haven't seen before. And that's very alarming. If you flip the nickel and turn it over, the other alarming thing is what's happening on the outpatient testing centers in the community that are not in your ER yet. Those testing centers are now going through the roof. They're the doctor's offices, they're public health departments, they're urgent care centers. And the alarming thing about that is that COVID positive rate from those testing centers, which is back of a napkin about 300 a day for us, is north of 30%. So the beads on the necklace are, you've got people out in the community that haven't even gotten in here yet. And then you've got those that are already here trying to find a bed for them. And I'll add one more comment on that. We are running 2 health delivery systems in Savannah. We are definitely infectious disease hospitals in the fullest sense of the word. Under normal conditions, your isolation rooms, you may have 10 people in there. So you're in the infectious disease business, but you're not an infectious disease hospital. We are now an infectious disease hospital. On the other side of that, you've got a very, very busy med-surg hospital. You've got cardiacs coming in. You've got people that fall out of trees that need to get orthopedics done. You've got cancer patients. You've got them, they just wake up in the morning and they're not feeling that hot, and they come in here. So that's part of the challenge for all of us right now.
Do you know, Mr. Hinchy, how many beds do you guys have open and available at this time?
We have open a little around 400.
So there's 400 total beds.
Total beds. Now when you slice up that loaf of bread, that may sound like a lot, but when you start to slice it up, it's not. Now, why do I say that? Because you've got X amount of those beds for mother and baby. You got X amount of those beds for peds. You got X amount of those beds for oncology, because they're all disease specific. So the general med-surg population is less than that.
Can you, I mean, you touched on it a little bit there, but to be at this point where we're seeing higher numbers than we did when we didn't have a vaccine, is that frustrating for you guys in this hospital to know that there is something that can help with this and you're still staring at all these beds and all these people in your ER?
Yeah, the people that my heart goes out to are the caregivers on the floor. And they, before the vaccine came out, they're all hanging on a ledge. And you know, you all remember that. That's when they would walk out and the cars are beeping and honking them and giving them thumbs up, and all the pastries are coming in and the knitted masks are coming in, and everybody's just hanging on. And they were hanging on because we waited for that vaccine to come in. Then it came out, And we've got, of those 158, 88% unvaccinated. That's 130 people clogging up a bed. So the caregivers are not only frustrated, but I'll use a stronger word, they feel betrayed. And the reason they feel betrayed is they can't get their arms around the fact that the vaccination rate is not higher than it is in the community, especially the great job the public health department did, and it was all hands on deck. So I think those are the two types of emotions, and that really saddens me because I make rounds and I see it, and these are people that have taken care of all of us in various stages of our lives, and the good parts when we've had a positive baby, and the worst parts where you are just hanging on, and they are there, and they don't think this is a good use of our resources, especially if you go into these ERs. They are like a war zone right now, and we've got 20 people on a stretcher in the ED, COVID positive, waiting for a bed. So it's very sobering to them.
Can you talk a little bit, when we look at the numbers right now, how does that affect you as a hospital? Are you able to perform all the duties you guys need to, or is it now impacting kind of delivery of service? It's
a caution light right now. So the answer is we're still providing all the services that we need to. And the most obvious one, to me anyway, is elective surgeries. But that's a defined term, the doctor and the patient really has got to determine what is elective, and we're leaving that up to the physicians and the patient to determine that. But right now, we're open on all of that, but I say it's a caution light, traffic light, yellow light blinking, because that's going to have to be evaluated day by day, depending upon how many inpatient beds we have, and then equally important, how many critical care beds we have. Because, those patients are not elective. Open heart surgery patients are not elective, and you can't put them in an OR until you have a CCU bed.
What's the tipping point for you guys these days? Because right now we're talking about, around 150 COVID patients. How much more until we get to that point to where we're saying we're going to have to start looking at these quote-unquote elective surgeries? We're going to have to start rolling back and go full-blown COVID.
Not much more. I mean, we get north of 160, and we're going to seriously have a discussion. Now, what we're trying to do about that, there's only so much one can do. We can't go out and wave a magic wand and increase the vaccination rate here to 70%. So what you're doing to try to be practical about it is like anything else in life. What is it you can control? So we're trying to control what's in here. So we've got discharge planning, as an example, on warp speed right now. So we're making rounds 3 times a day on discharge planning, so that if a patient can be discharged safely to home with the right type of caregiver, the transportation, all the things that bottleneck that, we've accelerated all of that, so we get more bed turns. We've also brought accelerated home health, because home health is another arrow in the quiver to turning over your beds. And if you can discharge a patient to home, get home health to get a respiratory therapist in there, get them on portable oxygen, check up on them, use telehealth, and call on them, you can turn that bed over. So we've been working on that for the past 2 weeks to see if we can get a greater yield. We are also opened up floors that had been dormant. Now, the caveat to that is we've got to get a pair of hands at that bed, and that's an RN and usually a respiratory therapist, and they're in short supply right now, but we've got full speed ahead, so to speak, with contract agency nurses around the country to get contract nurses in here to do 2 things. put a pair of hands at the bedside, but for me, it's giving these caregivers some relief. It's just like being in the military. There's only so long you can be deployed. And then you've got to get out of there, and you've got to use some vacation time, and you've got to be with your family, and you've got to sit on the beach, and you've got to try to recharge your batteries. So those nurses are going to do two things. One, help us open a unit, but also for respite care for our caregivers so they can recharge their batteries. But the culprit in this, I'll just say to all of you here, is the low vaccination rate. If we try to keep this simple, and we're talking about masking, and we're talking about the variant, and we can, those are all really important, but if there's one thing everyone can do that's listening to this right now, we are asking you, please get vaccinated. And when you're thinking about that, maybe what we all need to do is put an RN's face on our monitor. I've got my family on mine. Maybe we put a caregiver on there. Maybe you put your OB nurse that got you through a delivery. Put something on there so you can connect to the caregivers, because we're doing it for them, but I also want everyone to be a community citizen, because we've got to keep the med-surg side of this place open. And one of us in this room is going to need that. And it's not going to be at a convenient hour. And so let's do it for the sake of the community. You know, it's not a racial thing, it's not a politic thing, it's not a financial thing. It's just being a good Savannian in Chatham County so we all can take care of each other. And if we can get that vaccination rate up, we can take care of those COVID positive patients that get readmitted. We can take care of them. We just can't take care of 80–90% of them being unvaccinated. That's what's putting the stress on the elastic band.
And you see what's going on in Louisiana and Florida. Obviously, I think those are two of the states that are being really, really hard hit, more so than here right now. Are you concerned that Savannah could be next? We could be those next major hospitals that are seeing major, like, shortfalls?
Well, anything is possible, yes. I think, and we are very pragmatic about that. So in our planning, we are assuming a lot of different things. As an example, right now, we're going to look at getting licensed to see if we can open a school for our nurses, because we are unclear what's going to happen with the public school system. And if the public school system requires at-home virtual learning, then the nurses that are working here, or their partners or whoever, is going to have to stay home. So we're getting ahead of that curve, so to speak, because we want to plan for anything. And right now, anything is possible. And we're spending a great deal of time on the supply chain. Thank goodness we kept our orders up on N95 masks, gloves, gowns, OR scrubs, all of that. We never let it up. We just inventoried it. That's really a good thing. And the other thing, though, that's getting a little tighter is therapeutics. So when you walk into the ER, you'll go out with remdesivir or things like that. There's a contraction now in the country on the therapeutic side. That's a caution light. And there's a caution light on oxygen right now. Those two things. PPE is okay here, but the squirrel is popping out of the head on the other two. So what we do is we get multiple suppliers, so we don't have all our eggs in one basket. But the larger picture is we're very concerned. And you know, I'll plant another seed in all of your mind on this. I don't know about y'all, but when I get the flu 8 or 9 months from now, I don't really worry about having my DNA altered by the flu. I just felt horrible. You've got to worry about your DNA being affected by the COVID virus. It's too new. You could be restructured, your immunity system could be altered because of that. So if people say, look, I'll just go in the hospital 14 days, I'll tough it out, that's true, but that's myopic. The downstream effect from this virus, because it's so new, it's entirely possible, because we haven't gone through 2 or 3 years of living with it, that your DNA could be compromised. So when you think of that, it's not getting through the flu. So the compelling reason is, let's do something. Let's get vaccinated for all those reasons.
Can you talk a little bit, visitors policy at this point? Are you guys still allowing people to come through and to see patients, obviously with so many in here right now?
Several weeks ago, we were not allowing anyone. We opened it up to 1, and tomorrow morning it's closing to nobody. The exceptions to that will be mother-baby, I believe, outpatient surgery. We want a caregiver there, because on the discharge planning, when we go over your meds and things like that, we want a partner there with you, and maybe some selected chemo patients. Aside from that, the visiting policy is being shut down tomorrow. One of the disappointing factors on that, when it opened up, and I had a meeting on that this morning with the nurses, it was very difficult to get the family members, once the RN walked out of the room, to keep their mask on. As soon as they walked out, that mask came off. So if everyone were compliant, if we were all good citizens and just try to do a little bit of this and all kind of pitch in, we can do a lot more. What we ran into, nurse walked into the room, mask gone. Nurses then says, excuse me, would you mind putting your mask on? So it places the nurse who's running around and has got one goal in mind, which is taking care of that patient in the bed, not being the mask cop. So we don't want to go down that rabbit hole. So unfortunately, what started out with the best intentions ended up complicating the patient. And so when I heard that, that was it. Visitations closing tomorrow. So what everyone can do, again, I'm trying to keep this simple because it's a very complicated thing. Please have kitchen discussions about vaccination and try to influence people in a caring way, not a scolding way, but some honest dialogue that is something that they can do. We've inoculated 160 million people. The clinical efficacy of it has been proven. It wasn't rushed to market compromising clinical efficiency. It was rushed to market for an entirely different reason, because the government paid for the clinical trials. Therefore, the pharmaceutical companies could enroll several million people in the clinical trial early, as opposed to doing it. That's why it happened, not just to get it out on the street. A lot of people don't understand that.
So earlier you talked about needing nurses for the number of patients or beds. How does that picture look like in terms of having enough personnel to treat COVID patients?
It's okay right now. It's not going to be okay in October.
Do you have specific numbers for how many, I guess, personnel you have now, and how many personnel you need, like per bed or per patient or something?
We're fine. I don't want to say fine. We're holding right now. Looking at the rate, we'll need 55 more RNs by October.
And this is more of a, I guess, sidebar question, but we've had 2 officers in the surrounding area, one in Chatham County, die of COVID complications. Do you have anything specific to say to these people in high-touch jobs, especially first responders like that, who have to communicate with various members of the community every day?
Well, I'm hoping that they're all vaccinated, first of all. And my heart goes out there, and we are going to have those that are vaccinated and still come down with COVID positive. We've got them in here now. The good thing, the refreshing thing about that is that the symptoms are mild to moderate, the mortality rate is low, and the length of stay is low. So we're getting them back on the job. But everyone that's contact with a patient has to be vaccinated.
In this hospital, that's the requirement.
Yes. No, it's not a requirement in the hospital. We're at 70%. We're at herd immunity here.
Okay.
And we have I don't think we've had any COVID positive acquired infections in the hospital. The hospital is safe. Everyone here is in PPE, everyone wears a mask, and we got herd immunity here in the hospital. We've got 3,000 people that have been vaccinated.
Shifting away from COVID for a second, is there any update or updates you can give us on the ransomware attack?
Yeah, it's all we're fully operational right now, thank goodness. There are a few hot spots where we have to change out computers. But in terms of the hospital being back electronically, we're back electronically, which was a big sea change for us because we went from a fully integrated system to a paper system, and we haven't done that in 25 years. So that's the good news. You're required by law to send out notifications of any patient information that we think that what they call the threat actor may have gotten when the servers were compromised, and all those letters went out last Tuesday, and so the patients have been notified. So we're putting them on alert, and we're offering security, credit security, and all the things you need to do. The criminal investigation is still underway by the governmental authorities, so I've got, unfortunately, duct tape on what the status of that is, and there's not much more I can say about that. And then during this, like anything else, we've kind of looked at every aspect of the security here. These entities are, they reinvent themselves at warp speed. So when you incur a ransomware attack, when you are putting up your drawbridge and putting up your moat, they've already got the R&D people, whether it's in a Soviet bloc country or not, kind of reinventing how to do that. So we've hired several national companies, one who does all the security for Amazon, and we put in all of these firewalls to make sure we mitigate that as best we can from ever happening again, because once is enough.
Shifting back again, can you talk a little bit, you mentioned that you guys are looking at the potential of reopening some of those spaces that have been dormant. Are you guys expanding? Do you think a field hospital is needed? Are you looking at ways you're needing to add beds for these people?
I don't think a field hospital is needed, and I'll tell you why. The logistics of running a field hospital, although we would do it if it were a last resort, are so complicated because it's not integrated in your tower. So all the support departments that the nurses need are all here, all go up the same elevator shafts. The food goes up, material supplies goes up, the docks are here, and they can get it like that because they do run out of things, especially as the census goes up and down. So the anatomy of the hospital to help the caregiver is all here. So our preference is, as long as we can, to keep it in here because we can get delivery to the nurse, pharmaceuticals faster, which ultimately ends up getting to the patient faster, which is the reason why we're all here.
Are you guys expanding the spaces within the hospital to avoid that then?
We are, yes, we are.
Do you know how many patients occupy those beds that you've had to add?
How many are in the hospital
So
now?
if you guys have had to add space for those patients, do you know about how many patients are filling up those beds at this time?
They're not
Okay.
filling it
So
up.
they're not, the
No.
patients aren't using those beds
No.
at this time. They're just
Right.
there if
Correct.
it continues to rise.
That's right.
Okay.
Again, because we are trying to run 2 hospitals, so we're very sensitive to the med-surg needs of patients. And you know, we lived through that 15 months ago when care was delayed, and it requires a lot of thought. And we'd naturally look at all the alternatives we could, but we're not there yet.
Can you talk a little bit about specifically the Delta variant? Like, are you guys seeing the harsher outcomes for patients, especially if they're unvaccinated, because of this new variant?
We're not seeing unvaccinated patients harsher outcomes from unvaccinated patients because of the variant. The average age is dropped by 10 years, which is very unusual. So the unvaccinated people in here now are around 54 years of age, plus or minus. And as I said earlier, their length of stay is around that 8-day category versus 15 when this thing hit the fan. And also the mortality rate is very low. Now, we are seeing people that have got both shots of Moderna and Pfizer back in here. We don't know if it's because of the Delta variant, because all that lab work is sent to the CDC in Atlanta, and we don't get the report back. We just know they've had the shot, but I can tell you that they have very significant comorbidities. COVID positive patients that had gotten the shot that have now got COVID again. Severe diabetics, chemotherapy patients, cancer surgery patients. So what they had gone through had taken its toll on their bodies and probably made the suit of armor a little thinner than what it would have been, which is frankly what we're concerned about. If you get this virus, there's no free lunch on that. And how that affects you a year from now, I don't think any of us can say with any certainty. But my point is, why roll the dice? Why take a risk you don't need to have to take? And we're in the health business, and you don't want to risk your health. You may take a shot and putting 5 or 6 more pounds on you and having desserts or increasing your carbs because you can get that off. But you don't want to fool around with something that may have lasting effects on you that you won't have any control over. And at this stage in your life, you don't have a clue what that means. But what I do know you'll have regrets years from now. And why have regrets when something can be done about it? And I've always said, because I've been doing this for so long, there's a lot of risks one wants to take in life. Don't take it with your health. Don't be cavalier with your health, because we were born healthy, thank God. It's a gift. Don't play Russian roulette with it.
One more question from me. When it comes to seeing these numbers rise, I mean, you talked about over the weekend seeing 145 and then 150 today. Is there fear there for what this looks like in the coming days and weeks and how you guys handle it?
The amount that the bed needs going up is very alarming. So I'll dial that back, and I'll start the beginning of May. We had a little celebration, a mild celebration, but we all wanted to smile a little. And that first week in May was the first time we had 0 inpatients. Now that was a big deal, a big day, and you know, we wanted to celebrate that a little, although we were very sober about it. It was something to celebrate. So here we are in the middle of August, The alarming thing about that is the rate of the acceleration of the beds coming in, and it's going up in 10-bed increments. It's going up from 85, 95, 105, 115, and that's with bailing out as much water in that bathtub with discharges. So you're freeing up those beds. You're not static. You're discharging 15, 20 a day, and you're still adding 10 more onto your pyramid. So it's that 10-bed added increment, which is large. It's not one bed, 2 beds. That's very concerning.
With schools going back to in-person learning just a couple weeks ago, are we seeing a lot more now children being hospitalized due to COVID in the first couple of weeks?
No, children, not yet. Thank goodness. Great question. Children, not yet. No, and the ones that have come down with it that we're aware of have had milder symptoms and have caregivers at home. So thank goodness we haven't seen the children yet.
And just to confirm, you said the average age of the patients was?
It's 54 now.
Okay.
It was about 64 to 66 when we were at our peak.
Okay.
So that tells us it's a different demographic that is in here. One positive news in all of this is that there are minimum amount of nursing home patients here. Thank goodness. Most of them have been vaccinated, as you know, and they're in a pristine environment with visitors. So thank goodness that the nursing home population is not in it, which has a much higher mortality rate.
And just this isn't for camera, I'm just wanting to check. Have you guys brought in extra staff at this point, or you're looking at those now?
We've brought them in. We've already brought in. We've brought in, I would say back of a napkin. I mean, I'm giving you a range.